Welcome back to another episode of HealthCap Weekly Wrap.
We've got a great mix of stories this week, from a groundbreaking new insulin option for residents with type 2 diabetes to a major FDA transparency initiative.
An important Tardive Dyskinesia resource, new thinking around physical activity and aging, evolving dialysis care models,
Increased CMS enforcement authority, and a rare labor law victory for a skilled nursing provider.
Let's jump right in.
One of the biggest healthcare stories we've seen recently comes from Medscape. The FDA has approved Awiqli, also known as icodec, the first once-weekly basal insulin for adults with type 2 diabetes.
That's a pretty significant development. We've lived in a world of daily basal insulin injections for decades.
Exactly. The big headline is convenience. Instead of taking a basal insulin injection every day, eligible individuals may be able to receive one injection a week. That drops the annual number of injections dramatically and could help address one of the biggest challenges in diabetes care, which is treatment adherence.
On the surface, that sounds like an easy win. Fewer injections, less burden on residents, less medication administration time for staff.
Potentially, yes. But the article does a good job of reminding us that this isn't as simple as replacing daily insulin with weekly insulin for everyone.
Oh, what are diabetes experts concerned about?
Patient selection, primarily. Insulin needs can change because of illness, activity levels, weight fluctuations, dietary changes, hospitalizations, and other factors. When a medication lasts an entire week, clinicians have to think differently about adjustment.
So, flexibility becomes a bigger discussion.
Exactly. The article also discusses hypoglycemia concerns and recommendations that individuals starting weekly insulin receive appropriate education and, when possible, use continuous glucose monitoring.
That makes sense. The convenience may be attractive, but organizations still need strong monitoring processes.
Right. For senior care professionals, the key takeaway is to watch how this evolves. This could eventually simplify diabetes management for some residents, but implementation will require careful assessment, staff education, monitoring protocols, and attention to reimbursement and insurance coverage.
Speaking of monitoring, our next story connects nicely to that topic.
The FDA has launched what it calls the Adverse Event Monitoring System, or AEMS. This story comes from Precedence Research.
This is less about a specific medication and more about how healthcare organizations access safety information, correct?
That's right. The FDA has essentially created a unified dashboard that brings together multiple adverse event reporting systems into one platform.
And those systems were historically scattered across different databases, weren't they?
They were. The agency says it was managing roughly 6 million reports each year across 7 separate systems. Those included reports related to drugs, biologics, vaccines, medical devices, cosmetics, foods, tobacco products, and veterinary products.
That's a lot of information living in a lot of different places.
Which is why the FDA describes this as a transparency initiative. The new system is intended to provide real-time access to adverse event information while improving data analysis capabilities.
I can see why senior care leaders should care about this.
Absolutely. Communities routinely evaluate medication risks, vaccine issues, devices, and product-related concerns. Faster access to adverse event information could help clinicians identify emerging trends sooner and make better-informed decisions.
The other interesting piece was the projected cost savings.
That's right. The FDA estimates the consolidated system could save approximately $120 million over 5 years, while reducing the need for Freedom of Information Act requests because more information will be available directly through the platform.
That's a good example of technology improving both transparency and efficiency.
Now let's stay in the clinical realm and talk about a resource that many senior care professionals may find extremely valuable.
We're talking about the 2026 Tardive Dyskinesia Toolkit.
This is one of those conditions that often doesn't receive enough attention.
Exactly. Tardive dyskinesia, or TD, is a movement disorder associated with certain medications, particularly long-term antipsychotic use. The toolkit focuses on helping healthcare professionals recognize symptoms earlier and improve assessment and documentation practices.
And one challenge is that symptoms can be overlooked.
That's one of the major points. TD can develop gradually. Residents may exhibit facial movements, lip smacking, tongue movements, blinking, finger movements, or other involuntary motions that can be mistaken for normal aging or unrelated neurological conditions.
Which means frontline caregivers are often the first people in a position to notice subtle changes.
That's exactly right. The toolkit emphasizes routine observation, interdisciplinary communication, and use of standardized assessment tools such as the Abnormal Involuntary Movement Scale, commonly known as AIMS.
I appreciated that it wasn't just focused on diagnosis.
No, it's very practical. It discusses documentation, care coordination, communication with prescribers, and ongoing monitoring.
For senior care communities, that's especially relevant because many residents are receiving medications associated with TD risk.
And earlier recognition can create opportunities for clinical intervention before symptoms become more disruptive to daily life.
Let's shift gears a bit and talk about something every community tries to encourage: physical activity.
This comes from the Mather Institute report on barriers to physical activity among older adults.
What struck me about this report is that it challenges the assumption that people avoid exercise simply because of physical limitations.
Exactly. The report suggests many barriers are psychological, social, or educational, rather than strictly physical.
Things like confidence and motivation.
Confidence, motivation, fear of injury, misconceptions about aging, lack of social support, and limited understanding of the benefits of physical activity.
That's a useful reminder. We sometimes focus on creating programs while overlooking the reasons people hesitate to participate.
The report encourages organizations to address fears, provide education, create supportive social environments, and offer activities that accommodate different ability levels.
I thought the discussion around beliefs was particularly interesting.
I agree. If someone believes physical decline is inevitable, they may see little value in exercising. Helping residents understand that movement remains beneficial at virtually every age can have a powerful impact.
For listeners managing activity programs, wellness initiatives, or rehabilitation services, the report reinforces that participation often starts with mindset.
And sometimes removing a psychological barrier can be just as important as removing a physical one.
Our next story takes us into policy and reimbursement.
McKnight's recently covered CMS's evolving perspective on dialysis services within skilled nursing settings.
This article was built around a CMS request for information, or RFI.
That's correct. CMS is exploring ways to improve access to dialysis services after hospital discharge and is seeking input on whether additional payment incentives or demonstration projects could encourage more dialysis support within SNF communities.
That could be a meaningful shift.
Potentially. The article suggests CMS may increasingly view SNF providers as active partners in maintaining dialysis treatment rather than simply places where dialysis recipients reside.
That sounds promising, but the operational side is substantial.
Very substantial. Providers discussed equipment investments, staffing requirements, infection prevention measures, clinical oversight, reimbursement concerns, and physical space needs.
So this isn't a simple service line expansion.
Not at all. But there are potential benefits. Residents may experience fewer transportation burdens, improved treatment continuity, and better coordination among care teams.
That's especially valuable for medically complex residents who already have multiple appointments and transitions of care.
Exactly. The article is really asking organizations to start thinking strategically about whether future reimbursement models could make these services more practical and more attractive.
Now let's talk about a story that generated a lot of industry discussion.
McKnight's covered new CMS exclusion authority that some officials describe as a force multiplier for fraud enforcement.
On paper, stronger fraud prevention sounds difficult to argue against.
True, but the article's real focus is the tension between enforcement and due process.
Tell us more.
CMS has been expanding its ability to identify and potentially exclude providers from participation in Medicare and Medicaid programs. Officials point to increased use of AI tools, predictive analytics, and sophisticated data monitoring to identify suspicious patterns.
And many stakeholders support more aggressive fraud prevention.
Right, but attorneys and provider advocates have expressed concerns about transparency, appeals processes, and how decisions may be made.
especially if AI systems incorrectly identify legitimate providers.
That's one of the concerns raised in the article. Critics worry that data-driven systems may generate false positives that place organizations under scrutiny before they have an opportunity to explain what happened.
Which is particularly important in long-term care.
Exactly. For senior care organizations, exclusion from federal healthcare programs could have enormous consequences. That's why the discussion isn't simply about fraud enforcement. It's about balancing accountability with fairness and due process.
The takeaway for leaders is pretty straightforward.
Strong compliance programs, strong documentation practices, and ongoing monitoring become even more important in an enforcement environment that increasingly relies on data analytics.
And finally, we have a labor relations story from McKnight's that stood out because of how unusual the outcome was.
This involved Riverwood Center in Florida and a National Labor Relations Board case.
Correct. Managers at the 240-bed community were cleared of allegations that they interfered with employee union organizing activities.
The case had been moving through the system for quite some time.
It had. Following unsuccessful unionization votes in 2024, multiple objections were filed. Most were dismissed, and one remaining allegation centered on claims that leadership created the impression that employees' union activities were under surveillance.
The decision ultimately came down to evidence and credibility.
That's right. An administrative law judge reviewed the allegation, assessed the testimony presented, and ultimately concluded that the evidence did not support the claim. The remaining objection was dismissed.
What made the story noteworthy is that McKnight's described it as a relatively rare win for a long-term care provider.
Correct. Labor-related enforcement actions have increased in recent years, and providers frequently face significant scrutiny.
So, while the story is fact-specific, the broader lesson applies almost everywhere.
Yeah, it does. Leaders should understand employee organizing rights, maintain appropriate communication practices, document interactions carefully, and ensure managers receive ongoing training.
In other words, good leadership and good documentation remain valuable risk management tools.
They really do.
All right, that's all for this week's HealthCap Weekly Wrap.
Thank you for spending part of your day with us. We hope these stories help you stay informed, strengthen your communities, and continue delivering outstanding care for the residents you serve.
And if you'd like more insights on trends affecting senior care, be sure to visit healthcapusa.com/Angie's-blog.
Thanks for listening, and we'll see you next week.